Okay, seems like we are live. Hi, everyone. Thank you for joining us. I have Dr. Ellyn Silverman Linetz here, and we're excited because we're going to have a conversation about what can happen or what can we do as dietitians when we have some complex cases that we see in our clients, or we have mental health issues going on, we have eating disorders, substance use, and then how can we adjust our own approach. So we have Dr. Ellyn. I would love for you to just actually, let's start with an icebreaker. I'd love to ask you what your favorite beverage is.
Probably dietitians say water, but I really like iced tea. But it has to be really good. I'm Scottish, so it has to be really good black Scottish tea.
Okay, nice. A nice black Scottish tea. That sounds lovely, especially as it's summer's coming. I'm thinking iced tea.
Very nice.
I guess I'll share mine. I don't drink tea that often, but when I do, it's usually in the summer, the iced tea. My favorite is hibiscus flower iced tea. Because I grew up in Honduras, and that was a staple for us.
Very nice.
So different.
It's nice and refreshing. And I like sugar in it.
True. And with the hibiscus, just a little bit of lime juice too.
There you go.
Touch of aesthetic. Okay, wonderful. So we should be live, and I want to encourage anyone who's watching us to post your questions if anything comes up throughout, our conversation. We'd love to be able to answer some of your questions as well. So why don't you tell us your story, Ellyn? How did you get to where you are?
Well, I'm kind of the OG, if you want to call it that. It's been around for 30 some odd years working in eating disorder, substance, and mental health. And got my bachelor's degree in nutrition, but then I'm a physician assistant as well. So I went to medical school and got my physician assistant degree, and I ended up working in HIV care. So in the early 80s into mid 90s, I worked at USC in their HIV unit called 5P21, and worked a lot with clients that had been losing a lot of weight, obviously from AIDS or wasting. And then they got on new drugs and they started gaining weight. And these were my guys, and I'm sitting there going, and they're telling me about they were purging and they were restricting. And I was like, what are you doing? You just came back from just the brink of death. And now what are you doing? Like, what is this? So I didn't get it. So I was like asking my peers, and they're like, you know what, that's probably an eating disorder. And that's kind of how I got into it, was from my, gay men clients that were losing and doing things to their body because of the drug effects. So I got some more training in eating disorders, and really, really enjoyed it. And then I went into pharmaceutical sales, totally 360-degree turn, and sold an HIV drug, but it had a nutritional parameter to it. So there was a few of them that affected kidney status at that time and affected some other things that had to do with nutrition. So I sold that drug for a while, and I got into some other sales as a dietitian. And then when I went to finish that, I was like done traveling, done doing all of that. I really kept coming back to eating disorders because I had one myself. So in graduate school, given the stress and given the fact that I had kids and given the fact of everything, it seemed like the perfect solution to decreasing my anxiety. I developed bulimia. And, again, I got treatment back then, but a very different treatment than there is now. And whether or not that's good or bad or ugly, it's just the way it is. So I decided that was something that I really thought would be a great niche for me. And so I started working for an eating disorder treatment center, and I've worked for a few over the years. But then I went back into private practice and opened up Healing Nutrition Therapy, which is my practice now. And one of the first clients I got was a substance treatment center and mental health center. And I really enjoyed working with those clients. And what would happen is trickling in would be eating disorder clients, and nobody really kind of dealt with them. And they were kind of like putting them over to the side, like they had a certain house for them, and like they were like isolating them. I'm like, that's not gonna work. Like, because they keep rotating back for alcoholism or drug abuse, and or the combination of mental health issues. So I'm like, that's not working. So what I did was I incorporated into this program a program for all three, so a co-occurring diagnosis track, and that worked really well. And that I was with that company for about 5 years and had my private practice as well. So ended up seeing a lot of these clients that came out of treatment centers, both alcohol, substance treatment, and eating disorder treatment centers, because I got a lot of referrals from a lot of the therapists that I worked with. Right. And me being a PA, I can go deeper than just I don't mean to say just a dietitian. Somebody will get offended by that, but I had to go deeper. It wasn't just about the food, and we all know that, but our scope of practice sometimes keeps us in certain areas. And I'm from the East Coast. Like, I don't have boundaries sometimes. And so it just didn't fit my personality to stay there. So I, again, got more education in psychology, studied CBT, DBT, somatic therapies, and incorporated them into my practice. And that's been very helpful. So my practice now is like 95% eating disorder, mental health, and substance, and the combination of those, and or maybe around the parameter one of those. But the other kind of client that I actually am doing some research on right now are SEED clients, which are severe and enduring eating disorder clients. So these are clients that have had an eating disorder for more than 10 years. I don't know what the technical definition is. I don't even think there is one. But most of my clients have had a pretty severe eating disorder for 30 or more years. And these are clients that come to me that everybody else has decided they can't work with, whether liability issues, they don't think they're going to do anything with them, they're not going to recover. I'm sorry, that's baloney. Like, you can't just abandon somebody. Yeah. You can decide that you don't have the training to do that or the bandwidth to do that, but refer them to somebody that can. So that's the other client that is like, I love those clients because I feel like sometimes I'm their last person, them and myself and their therapist. And so I work a lot with that. But my focus also is on getting adequate education to treatment centers, because what we found is that if substance treatment centers, if they get an eating disorder client and they're already trying to get them out, well, I don't even know what the current statistics are, but it's about, I think the last time I checked, it was like 30% of all mental health substance abuse clients also have an underlying either disorder.
Sounds about right.
Disorder, yeah. And so if you're missing out on those clients, so either you got to hire somebody to help you with them, to keep them in treatment for their other things that are going on, or you're losing a whole population. So for treatment centers, it's behooving to have a dietitian that knows what they're doing to keep that person in treatment. Otherwise, they're going to be going through a revolving door. So I do a lot of education. I work with about 15 treatment centers in the LA, Orange County area. I'm their dietitian, and I do consultation as well.
That's amazing. Much, much needed. I was working in a substance use rehab facility, and that was a wide awakening for me, because when I was hired, I was told, oh no, we don't treat eating disorders here. And I said, okay, fair enough. Then I won't be seeing eating disorders, right? Wrong. So many of the clients that were coming through those doors had the underlying eating disorders that were just popping up when in recovery. Yeah. So definitely fascinating population to work with.
Yeah, and you can't just like put that on the back burner. You have to deal with it at the same time that they're dealing with their other issues, and because anxiety and depression just drive an eating disorder, body image drives an eating disorder, and again, it's like we can't just ignore it.
True.
And sometimes it's done, and then they end up back in treatment, or
And I'll be honest, and I'll say that no one there had the training to be able to handle active eating disorders. Not the medical staff, and not the psychotherapy staff, right? The clinicians. There was one clinician who was getting training as I was getting training. We're going to the same trainings, but by no means were we in the level where we'd say like, okay, we are proficient and we can handle eating disorders that are coming through the doors. So
Well,
we
the other thing you need to know is that a lot of treatment centers are not like licensed, as they say, for an eating disorder. So there is no clinical licensing for an eating disorder track in the state of California, by the way. So
okay.
they can provide services, but they don't feel qualified. So then they end up shipping these clients out.
Yeah. So I ended up having to do some more in-service for the rest of the individuals there, just for the medical staff to know what to look for, what types of things to screen for. And then there were some cases where we had to find a place where they could treat both co-occurring conditions at the same time. They were better qualified than we were.
Right.
Absolutely. So this is definitely a fascinating and challenging population, because not only are they recovering mentally, emotionally, physically, there's so much that's going on that we have to walk on the line between recovery and comfort for recovery, so that they can actually be at peace with the work that they're doing and be able to grow. I'm curious, was there a particular event, or was there a particular moment that you remember that said, okay, this is it, this is my calling, this is what I'm going to do?
I'm kind of the person that likes to focus. Like, I need to just focus on something, because sometimes, I take 100% insurance. And let me just say something that I heard the other day is that clients that use insurance are not ready for change. I heard that somewhere, and I just really got my hackles up, because I only take insurance because this is a population that sometimes doesn't have the money to pay a dietitian $200 for an hour.
Mm-hmm.
Okay? So what, are we just going to leave them there? No. Okay, I'm fortunate in the fact that I do have white privilege. I'm also Cuban American, so we got that going on here. But I can afford to do that, right? But that's also meeting the needs of an access area that's not well covered. I live in Long Beach. So again, I'm not in West Hollywood. I'm not in, Westwood. So these are clients that I've come to me are ready for change. So I just want to put that out there, because that just really I heard that and I was like, not so much. Like, just because you're paying cash for something doesn't mean that patient or client is not ready for change. They're actually really ready for change. But they can't afford it. They have their insurance. Why not use it? So I don't know how I got off on that tangent, but I had to say that.
No, but I'm glad you did. And I think many dietitians out there might have that misconception, because they might be seeing clients who maybe are dwindling more between the readiness, being very ready, to being not so ready and going into ambivalence. And that's totally normal. And we need to be able to be equipped to have the conversations to really get them to a place where they feel they're actually ready, willing, and able to make a next step. So I think a lot of that is actually also on us as dietitians to know how to navigate those conversations.
Oh, absolutely. And again, I try to meet everybody where they're at. But usually if they're coming to me, they're coming to me out of need. It's not like, that they were told that they have to go. I mean, some are, because their therapists tell them, they're not going to work with them if they don't have a dietitian as well, which that happens, and I get it. But I've totally focused on eating disorders now. So people will call me from the insurers and say, can you see me for diabetes? You can see me. I do not do any weight loss, not intentional weight loss. Haven't done it for about 8 years. But again, weight changes when you make lifestyle changes, and I support that. I'm just not, I don't take anybody, and I don't prescribe. So I'm a prescriber of drugs, right? So I don't prescribe any GL1 drugs. I don't work in that area of care. But if somebody's on one, I will support them, right? Because that's their choice, and I'm honoring their choice. But I don't see diabetes. I don't see high blood, unless it's part of the situation that's going on with the client. I also do GI, because as a PA, I worked in GI and immunology. So I still see HIV clients. I still see GI clients with, like all kinds of things from, celiac disease to irritable bowel to, short bowel syndrome to everything. But those are the like two main areas of care.
Okay. And I'm just curious, since you are a PA and also a dietitian, when you're billing insurance, do you bill as a PA or as a dietitian, or do you do a combo?
So in the state of California, you have to work under a physician to
Okay.
be able to bill insurance as a PA. So I'm billing as myself, as in my own private practice and my sole ownership. Yeah. So it's as a dietitian.
Okay. Wonderful. And you've been able to get pretty good reimbursement that way.
Again, it depends on what you consider good reimbursement, right? So I'm just, again, I feel like I can handle that, and I do pretty well, let me tell you. So I try not to have a waiting list, but I don't go over a certain amount of clients per week because I'm very hands-on. Not only do they see me once a week or twice a week, depending on what they want, but I'm in contact with them almost every day through all kinds of meditation, and I do some other things. I'm also a certified trainer, so I do some work with my clients on getting their exercise or movement regimen, into something that works for them. So I'm in touch with them a lot. But yeah.
Okay, so that's amazing, the fact that you're able to connect with them beyond, the sessions, and know that you're able to really support them throughout their journey.
Yeah. And again, as a PA, you have that peer-to-peer contact with the physicians and DOs and NPs, and you can ask for labs, and you know what you're talking about as far as asking for labs, and you can read them, and I can read EKG. I mean, because it gives me a little bit of more practice so that, I'm looking at the person as a whole. So, that helps the client to feel more that you're not just talking about my food and what I ate today and how much they eat, because they've already gotten that a lot of times if they've been in treatment. So step down from treatment, inpatient, RTC care, you need to have a good quality dietitian to be able to walk with them. It's not 2 weeks, it's not 3 weeks. It could be 4 years down the road that they still need that support in some way. Yeah.
So then I'm curious, can you walk us through like an example of a very challenging case that you tend to see where you have some of these co-occurring conditions? And what comes to mind is a lot of GI issues happening as they're also recovering. So I'm curious if you could walk us through a typical case and how you would approach it.
Sure. So I will use Susie Q because I love that name. I have quite a few clients that have come out of residential substance treatment that come to me with an underlying eating disorder. What happens is I evaluate them for where they are in their eating disorder. And usually what happens is when their alcoholism, their substance abuse is really active, their eating disorder is taken like a little bit of a back seat. It's quiet. Mm-hmm. But when they become sober, you're taking away first of all, main energy source. Let's just say it's alcohol. So, that carb load that they're getting through alcohol, they've not been eating a lot of times because when they eat, they don't get the buzz. So a lot of times they're malnourished to get go, right? So they're decreasing carbs because they're not drinking alcohol, and they're probably malnourished. So first of all, I get them on a regular kind of well-balanced eating plan. I don't call it a meal plan because I can't stand that. But I get them eating again, just eating again, getting in the habit of eating something in the morning, something for lunch and something for dinner. And that can take weeks. Mm-hmm. They're still going through the absolute chaos of their eating disorder, telling them, you gave up the alcohol. Now you're going to put carbs back in. That's going to, oh my God, that your body's going to blow up. Mm-hmm. So I detangle that and say, yep, your body is going to change because right now you're actually renourishing it. So we get that kind of going, get their meal plan, get them starting to move down the highway of eating more frequently. And we really have to deal with when they come out of substance treatment, why does their eating disorder get loud? Because they've lost control of the thing that they thought they had control of, and they go to something they think they also have control of, and they don't. So here now they have two things that are out of control, right? I also don't use the word relapse because, and I try to not use the word binge, relapse. There's a lot of triggering words that people have heard over the years.
Mm-hmm.
So why am I going to continue to throw that in their face?
I like that.
You know, I walk them through whether they need some support, refuge recovery, step recovery, AA, whatever floats their boat, so that they're getting maximum support in their substance area. And then we tackle the eating disorder. And again, usually one started because of anxiety, depression, other mental health issues. So also I'm making sure that that piece is being worked on. All my clients have to have a therapist.
Mm-hmm.
I do not work with clients that don't have a therapist. And if they don't have a therapist, I find them a good one that's covered by their insurance or whatever. But I have to have that support because I'm going to be pushing buttons.
Yeah.
And those buttons don't go past my pay grade. I need to have a therapist to be able to deal with that. So we kind of unpack all this stuff over a course of weeks, but I do a full-blown assessment. I'm looking at their past history, any, abuse and trauma, what treatment have they had, how many times they've been to treatment. One of my clients right now I think this is their 45th alcohol detox. And that person still hasn't really dealt with their eating disorder, and they're now back in eating disorder treatment. And again, it's letting go, as we say that we're powerless over something. Again, it doesn't always fit that model with an eating disorder because eating disorders are not addictions and they don't need to be detoxed from. Okay.
Mm-hmm.
I don't believe in food addiction either. I think that's a bunch of baloney. So again, if you put in the addiction model, that thing doesn't fit because you still have to be constantly around your abuser, your addiction, if you're calling it that. So how are you supposed to work through that if you're constantly being berated by it? So what I try to do is have them find some peace, whatever that looks like with food, and we start off very small. We start off, again, by just trying to get them to eat more often and just feel what's coming up for you at each meal, what's coming up for you regarding how your body is changing. And they need that constant reassurance that this is the process. Yes. A lot of them don't trust anything because they've been traumatized by treatment. Again, like if you talk to me maybe 10 years ago, rah treatment centers. At this point, I have a very few that I would refer to. I'm very particular, and they have to really be vetted by me to be referred. Again, if it's bulimia or severe anorexia and they need medical stabilization, of course, I'm right there with you. But if they are willing and somewhat ready for change, we can probably keep them out if they have a good support team. Right. So I don't have more than 20 to 20, 25 is the highest amount of clients I had at any time. And unfortunately, I have a waiting list at this point. So I'm looking at hiring somebody because I can't let them sit. I just can't. And I work with those 20 to 25 very intimately because, it's an important, and we're having some good success. I'm having some good success, but my client is part of that they're able to, either get on meds or get off of medications for their mental health. They're feeling more balanced. They don't have that 24-hour-a-day noise that they have. They're not malnourished as, they're doing better with that. Again, nothing is a 100% success because these are chronic diseases. Mm-hmm. Okay. So we have to treat it as a chronic disease like we treat diabetes or high blood pressure or whatever. And I never say anybody is cured from an eating disorder. Even 35, 40 years out from mine, when I'm terribly chaotic or everything's overwhelming, I get a little tap on my shoulder. Hey, I know how to help you. And I'm like, go away. Like, I don't need that. I have the wherewithal at this point to say no, right? Yeah. But it doesn't mean it doesn't tap me on my shoulder and remind me of where I came from. So can you imagine if you have mental health issues, substance issues, and disorder issues? Like,
it's a lot. Yeah.
It's overwhelming. The rate of suicide in those clients is really, really high. So that's why I do what I do.
Yeah, and they need the support of trained clinicians that know what they're doing. And I'm curious, it is a chronic disease, it's a chronic condition that people need the ongoing support for. When
Mhm.
you're seeing clients, is it do they schedule one at a time, or do you,
I don't
you
do packages
know,
because
okay,
I don't think diet eating disorder treatment works like that. I just don't.
okay,
So I see them every week,
mm-hmm,
sometimes twice a week, depending on what they're wanting. We schedule the appointment. I call them the night before, 2 nights before, and remind them of their appointment. And I call them personally. It's not like I'm texting them your appointment is. They want to hear my voice. They want to know that somebody's not going to abandon them.
yeah,
And they need that extra support. So that's what I put out because I see the results by doing that. I don't have 10 people working for me. It's me, and I have sometimes a dietetic intern because I'm a preceptor for both Cal State Long Beach program and Sam Houston University in Texas. And so I sometimes have dietetic interns on calls, and I let, and these are clients that allow that, and they have to sign HIPAA papers, some
mhm,
papers. But, I figured that I need to train younger dietitians to not think in the typical weight loss mode. Like again, how many years did we get clients on scales and tell them that they didn't do something right between last week and this week for them to gain weight? How much trauma did we
mm-hmm,
on clients over the years? And I'm terribly guilty of that. So I've made my repentance by saying that I will not do harm to anyone. And so I teach dietetic students this because I want them to know that eating disorders, that substance abuse, this is going to be here for a really long time, and we need qualified people. And there's a lot of dietitians, young dietitians, that are now getting on board.
mm-hmm. Absolutely. So, given your experience, and I love the fact that you said, I just call them instead of getting a text message, just call them. And I get excited too when I get a reminder call. Reminder texts are useful because otherwise I forget things, but
Yeah,
a reminder call is wonderful.
yeah.
And I'm curious if you have any other tips that you might want to share with dietitians who are struggling with client retention,
You
just
know,
that
yeah,
we take for granted.
Yeah, I think that also, I think it's important to get to know if you're going to work in this area, you need to go get to know the medications very well
Yeah.
because a lot of them have side effects that affect the nutrition and the body. And so, one of the other clients that I worked with, again, most of them have I call it the trifecta. So I have a client with bipolar disorder. She was a narcotic user, opioid user, and she has an eating disorder. So she finished treatment. She's been doing really well with her sobriety. Okay. But her eating disorder is still really, really active. So right now, what we're doing is she was on some medications that weren't really covering her depression. And she has sort of a really, really reluctant uh, medication regimen. Which what I mean by that is that she's tried lots and lots and lots of things and nothing's working. We finally found a drug that's working, and so that drug helping her depression also in turn helps her anxiety, which has
Mhm.
helped her to not be as focused on her weight. Her weight was her major focus for not going on meds. So can you imagine having a person with bipolar disorder with psychotic features and they're not on medications? So once we finally got her convinced that it started working, her ability to decrease her need to lose weight was greatly affected, and she's absolutely doing better now. But that was her focus because that was her only control. So what we do also with the therapists help them see other ways of controlling things and that they do have control of pieces of their lives. And let's boost that. Let's make that bigger so that you don't feel like you don't have, right? So they're working on relationships, they're working on, their self-confidence, they're working on self-esteem. And as far as food goes, it's like, I come from, all foods are fine. I don't even put it in moderation type thing. I just put it in because I want people eating. Like I don't really care at the beginning, like what they're eating because they're coming from a place of total restriction. I
100%.
don't care. Like really, to my clients don't have access to lots of money to, to not buy something that may have, be overly processed or whatever. They just have money to get the bare necessities. So we work with that, and then again, when they can or when they do have more clearance on being able to cook for themselves or to, find other ways of nourishing, then we work with that. But at the beginning,
Absolutely.
it's
Meet them where they're at. Yeah.
I'd rather them have a protein bar than nothing. Come on.
Mm-hmm.
That's not the ideal. But again, they would go all day without eating, or they'd be spending money that they were, you had on drugs.
Yeah.
So now they have some money because they're not using. So let's put that money to some good, to some good use in getting quality food. But again, that's not always the case. These are clients that don't have that access.
Yeah, I agree wholeheartedly. And access to food is definitely going to be a big aspect, right? The environment and what they have access to on their recovery.
Yeah.
So you mentioned this one case where a client was just like really holding on to, the weight as the main outcome and not wanting to take medication because of it. And we see a lot of clients that are just holding on to that weight as an outcome, and they have a hard time losing that grip. Do you have any tips for how dietitians can approach clients like that so they can loosen that grip on the weight itself and then open up to different strategies or different things that they can consider that are also going to be beneficial?
I think they first have to learn how to trust you. I think trust is a huge word here when you're talking about weight, because they've been lied to and they've seen, oh, you're not going to gain weight in treatment. You're not going to. And I always, when people come into treatment, I always tell you, you know what? I'm sorry, but that's kind of like what happens in treatment is you gain weight. And the reason you're gaining weight, and I just explain it to them, is that their bodies have gotten used to a very low intake of nutrition. And so your body weight has decreased because of that. And when you start eating, which helps your brain, and carbs are the main fuel for the brain, when you start eating, again, your body's going to change. And instead of feeling fatigue or instead of feeling like you have no cognitive ability, those things are going to come back. Wouldn't that be great? Like, wouldn't that? So I kind of gain their trust and kind of walk them through what their body has done and how we can fix it. And I encourage them to learn how to be compassionate about the tool that they have here, that doesn't define them. So if they're in a tiny body, it doesn't define who they are. What defines who they are is what's inside. And you're a good person. You're a good listener. You're a good mother. You're a good sister. You're a good fur baby mom, dad. That's what you are. That's who you are. The body is going to show when you're feeling better in here, it's going to show out here. And I kind of walk them down that road. I've also been a very large body. And so I lost the weight because I had to go on a specific medication for my chronic illness. So me being in a smaller body is very weird. Very weird. And so it's been over the last 6 or 7 years that I've done my own work about being in a body that I really actually liked. And now I'm in a body that has a chronic illness. That takes its own. And I share that sometimes with my clients. So they don't think that, but that doesn't define me. What defines me is who I am as a person. And they're going, oh, okay, I get that. And they have been so detached from their body that I help them bring it in. I do some exercises with body image where one's called a compassionate hug. So instead of body checking or pinching, I have them do like an EMDR tap.
Okay.
And they touch that body part that they just are disassociated from. And I have them touch it or I have them rub it and say something that's just neutral about it. Like, you're going to be okay. You're part of me. Whatever else they want to do. And that works a lot. That actually helps them distract from body checking. So again, I have them just like take their bodies apart and find what they actually like about their bodies. What do you like? Your eyes? I love my eyes. My eyes are bright blue. Do they like their hair? Do they like their hands? And let's focus on those parts. What parts do you like? And then we'll work on the harder parts. So again, those are some of the things I do to help them not focus on the weight. And again, I always acknowledge that they are not comfortable in their bodies. I acknowledge that they want to lose weight.
Mm-hmm.
I honor them by acknowledging that, because people are always trying to change them, get them off of drugs, get them off of alcohol, change their. I don't, I'm like, I like you just the way you are, and I accept them for who they are, where they're at. I'm not trying to come in here and change their everything. I'm just trying to help them, support them, and educate them along the way. So they're doing the work, not me.
Mm-hmm.
And when they can do the work, and when they can see that aha moment that their weight, I think, again, society adds in here. We're always going to have this comparison to celebrities or to what's healthy and what's not healthy.
Yeah.
We can't get away from it. But if we can find a little peace in our body, we don't have to love it. I think body love is something that I can't understand, because I have never really loved my body, but I'm at peace with it, and I like it, and I'm okay with it. It's better than hating it. So if I can show them that, they can get to a place where they can focus on other things, and the weight is just not, right in front of them.
Yes. Thank you for sharing all of that, and for sharing your experience, and for sharing, some of these strategies that you use, because it's so much. And as dietitians, we're not necessarily trained in how to handle some of these conversations, especially when you have someone, when they're coming to you, they've had all this trauma, and they've had all of these past fails, and all of this baggage they're coming into our sessions with. And, we're taught basically to know what to do when a client's ready and into action, and they're like, oh, let's do some MNT. But all the other things that you mentioned, those soft skills, the listening, the pointing out their strengths and affirming those, and building up their trust in you, and all those things are so important. I'm so glad that you brought those up, because those are the foundations of being a good.
They also don't trust themselves. So if they can trust in you, then they can learn how to trust them. I had a client yesterday that I've been working with him for a little while, and he has somewhat of a cognitive disconnect when it comes to fullness. Okay. And so we were talking about trust. And I said, do you trust yourself to be able to stop, like when you're full? And I said, what else don't you trust about yourself? And he said, wow, I never had that question asked to me. I said, well, what do you trust that you can do? So he was talking about barbecuing or something. And I said, do you trust that, the stuff that comes off the barbecue, that you feed it to your family, your friends? Do you trust you do a good job with that? He goes, yeah, I really like doing that. Okay, that's number one. Let's go. What else you got? What else do you trust? I said, do you trust that you can get up out of bed and make your bed every day? Yeah, I can trust I can do that. So what I did was I built on these trusts that had nothing to do with food, and showed him that he can develop trust in those things. And therefore he can apply it to trusting that when he feels full, that he may be able to stop and not have the rest of whatever it is. And he can always come back and eat it.
Yep.
But right now you might be full. So I want you to be able to trust that. That big trust, these are clients, mental health, substance, and eating, have no trust in themselves. That's why they've been put in treatment, they think, because they can't handle themselves, or they're not to be trusted. Mom has to do all your meals for you because you can't be trusted. How many times have clients been told that? I can't trust you around my kids because I don't know what to use. So how do you
that? Yeah.
So you have to do that work with them. And MNT, yeah, I'm sure I do it along the way, but I don't spell it out, because I've moved past that in my own practice, and it takes experience. So somebody just coming out and starting to do eating with disorder treatment, they need to be supervised. They need to have education, somebody help them. I really encourage other dietitians, if they don't really feel comfortable, don't jump into this. You can do more harm than good.
Absolutely.
And I'm a supervisor for IADEP, and there's also kind of controversy about IADEP. Okay. But again, that's back in the day, that's what we did. Right. And so I am a supervisor. I do supervise dietitians too. And again, it's important that you have the wherewithal that if you don't know how to do something, if I was asked to do diabetes treatment, I wouldn't do it unless I asked for help because I don't know how to do it anymore. I don't know anything about renal disease. I wouldn't step into a client. So why would you step into something that is way over your head? And it's okay to ask for help. Dietitians are sometimes reluctant. Like, I'm going to lose a client. I'm not taking your client. I'm helping you to save your client within your practice.
Yeah. And that brings me to the next question, the role of mentorship and supervision in one's professional development.
Yeah.
So you mentioned getting supervision, you supervise others. I'm curious, what type of advice would you give to someone who is starting and they said, I want to work with like this trifecta of, conditions? Where would they get started? Like even just getting the knowledge to be able to start seeing these types of clients?
Again, they can look at supervision, but I encourage some dietitians, especially younger dietitians, to maybe work in an eating disorder treatment center or a substance treatment center. Although substance treatment centers want to have more people with more experience. They're not going to hire somebody right off the bat with no experience. I don't think they will. I'm hoping they don't because it's very complicated. But again, eating disorder treatment, they can get in on the ground level. There are no courses, believe it or not, that I know of that cover cover substance, mental health, and eating disorders in one fell swoop. If I was younger, I would go do it. Okay, but I'm not going to do that right now. But that needs to happen. Somebody needs to put something together, training.
Absolutely.
So listening out there needs to do that. I've started to write a book 3 times, and I don't know if I'll read it. But I think that needs to be too. Is that these are there are 3 coexisting. Coexisting is the word. Things that clients run into. So again, getting supervision, get some training. Again, not just jumping into it.
Absolutely. I sat in someone's dissertation for the past 3 years. I was working with them, and they were getting this really nice research project going on in a bunch of recovery centers in the Ohio area. And I'm hoping that something comes out of it beyond the dissertation because there's a lot of need for it.
Oh my gosh. Please keep me posted on that because I would like, I try to jump in where I can. My dissertation was on weight stigma in women over 50. And it's a whole big thing. And, one of the things that started one of my clients' eating disorder journey, unfortunately, was them getting weighed at their doctor's office, and the nurse and the medical assistant screamed to the nurse practitioner down the hallway who had the chart, "This client weighs blah, 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 blah." What? So you don't even know how you're going to affect somebody, but we need to think about these things.
Absolutely. And I'm just curious, as you're mentioning this, you mentioned your own journey years ago when you had treatment, and now you are someone who provides treatment for eating disorders. How have you seen the landscape of treatment change over the past few decades?
In some respects, a lot. In some respects, nothing. I think I'm trying to be careful here because I work a lot with treatment centers, and I think they have a place. But the mentality of some of the either new dietitians that are working there or staff have there's a lot of trauma that goes on, and that needs to stop. I'm starting to see it, especially, like if we talked about maybe even 5 years ago with clients that had atypical anorexia, in larger bodies and were restricting, or, so that's coming a little bit better to be treated a little bit differently. But again, whenever you put somebody in a treatment situation where you take all their control away, they can't have their phone, they can't do this, they have to be monitored, they have to eat in front of somebody, that sends a message. And then I end up on the outpatient side dismantling that message. Again, it's the trust message. I don't trust you. And then we say, we trust you, but we don't trust your eating disorder. It's one person. You're not talking to an entity that's sitting in their brain that's separate from their whole entity. So you're telling that person you don't trust them. You give them little bits of trust once they earn it, but you have no idea how that affects their psyche. You don't take into account a lot of times what happened before they came into treatment.
Mm-hmm.
So I feel a role for it, but I'm very, very careful about where I send people. And usually usually my clients want me to, I contact that dietitian, I contact that therapist in treatment. And, lots of times, dietitians take a role in the back seat and say, oh, when you get out, I'll see you. No, because they're the ones they've kind of gotten my trust. They trust me. And now you're putting them in a situation where they don't know anybody. So they need to have that little bit of touch so that they know they're supported not only by the treatment team, but by their dietitian when they come out. And a lot of treatment centers are open to that. They don't see it as, conflict. I'm not doing any treatment with them. I'm just saying, hello, how are you? How are you doing? I'm not doing anything with them because that's that role of that treatment team, but I'm not abandoning them. Where some dietitians will say, look me up when you come out, and then they don't have any room for them. What does that message send?
Yeah.
So I'm really into that continuum of care. And when they leave me and they're ready to go, once every year, I'll send them a happy birthday message. I'll just check in. How you doing? And, I have a lot of people that come back. Why? Because other things have come into their lives that have led them back down the path they were going, and they don't want to get too far down it. I have probably 10 to 15% come back after I've seen them. And I've seen some clients for 5-7 years.
Wow.
Because they want to be, and they're in their, most of it's sobriety. And I have been a sober coach in the past as well. But again, the eating disorder will come up when they're in chaos. So they want to nip it in the bud before they have to go back to treatment.
And that's a really important point that you bring up. How do you approach clients that when they're with you, they're saying, okay, I think we're done, Ellyn. I think I'm good to fly on my own. And then you're clearly maybe seeing that they still have some things that they need to work on, but we have to respect their autonomy. So what types of conversations would you have with those individuals?
I honor that thought in their head. If they feel like they're done for now, or they're burnt out, or they don't want to do this anymore right now. Absolutely. I always let them know the door's open and that they can fly on their own. And they might be at 75% of where they need to be, but that 75% can fly you very far. So I have them flap their wings, and they know that, if they need, that their therapist and myself will be there if they need it. But we don't, I try along the way to show them that they can do this, that they show them they can be successful. So they're not just leaving me and putting their whole body in the water. They've already been stepping into the water a long time already. And they know what they can do, and they know what they can be successful at. They're just having a little bit of, there's some things that I call them tentacles. And in my own eating disorder, EMDR was the last thing that I used to get the tentacles out, those deep-seated, rooted tentacles. And so I tell them that these are some of the tentacles that you may need a little bit more heavy-duty therapy for, or, that they just might be there, and you need to have the strength to say, not today. Okay? So, but I give them that feeling. I hope I give them that feeling that they can accomplish anything. That they're here.
Yeah.
They lived and survived through their overdose, through their, I don't like relapse, but just reusing of drugs because of a certain situation. That's all human nature, to go to a place of least resistance.
Yeah.
It's a human thing. So you're human.
And it's all very hopeful. Absolutely.
Yeah. Trying to give them hope is extremely important. If they trust you and you earn that trust, they'll understand when you say, look, I think you need a little bit more help, but I want you to just see how you do. Sometimes they come back within a few weeks saying, you were right, but you have to let them go.
Thank you for sharing that. Absolutely. So then we only have a few more minutes, and I'd love to ask you, let me see. Do you have any advice or words or wisdom you'd like to share with our audience, especially those who are not only aspiring to enter this field, but also those who might be aspiring to start their own private practice or have been, I guess, juggling with the rough start of a private practice? Because I know a lot of the audience that we have in this group are individuals who want to either start or have just started a private practice.
Yeah. Well, again, I've had a private practice from 1984. Yeah. I started out doing group homes when people were deinstitutionalized. They were putting these group homes. I started out with just buying a group home. Very little money in North Carolina. That's how I started. So what I say to people is that I worked for a company for a long time. So I had benefits, I had vacation days, blah, blah, blah. And then that position terminated last year. So I totally went 100% into my practice as of May of 2003. Okay. So I was supported for a long time, but my practice during the pandemic went up. I mean, it exploded. Like I could hardly even do my other job because my practice was so busy, which was amazing. Right now, I'm going to tell you that there's ebbs and flows.
Mm-hmm.
February was like really low as far as clients coming in. Now I'm getting like 3 to 5 a day, and it's getting like, okay. You need to have patience. So if you're going to go into private practice, I would say, please work a job before that, put some money away, invest, get your 401k going. I mean, do those things that are going to support what you want to do on this side. I totally work from home. This is my home office. This is what clients see when they see me. So I have like little inspirational little signs and things like that. I have a therapy animal right over here. So this is my little therapy animal.
Hi there.
4-year-old dog that's just like snoozing. But you got to have patience. So you need to have some money to start it. You need to do a business plan. I work with dietetic interns on doing business plans and entrepreneurship. And you got to have accountants. You got to have your licenses. You got to have malpractice insurance. I have malpractice insurance for my PA license and for my RD license. So again, getting training, hooking up with others, networking, joining, some Facebook groups that are really very good. Networking to get clients, get to know therapists. Therapists are my main resource. I'm on Yelp, but I barely get anything from Yelp. On Squarespace. Is it Squarespace? Something. It's not. I think that's what it's called. Squarespace. Profs. Health Profs, I think it's called. Those are where I get some. And then the insurance companies, I'm on their in-network provider list. And I'm one of the first ones. So ding, I get a lot of referrals from my insurers. So getting on an insurance, if you want to do that, you're going through ASH and the other ones that put together those lists, and you have to qualify for it. Get all that stuff together before you can jump out there. And I also say focus. Define what you want to do. Like, what is your area of care? If you want to be very general, fine. But I find that once I focused, the people came to me better. It was like I didn't have to worry about, I'm going to do diabetes today and high blood pressure and cholesterol and weight. No, this is what I do. That's helped me.
Absolutely.
Getting a bank account.
All those basics, yeah.
Yeah, I have, I can't remember the credit card thing. Square.
Yes. Okay.
Something like that, just making sure that's HIPAA compliant, and that you're keeping. I have an EMR, so I use Simple Practice. I use Recovery Record as my logging type of thing for my clients. It's an eating disorder based. Yeah. So getting all those players together, but then hook up with a dietitian that is in business, that has a private practice. And that's, again, what I do is I walk these students, how I develop my business plan. How does it change every year? My profit and loss statement. Where do I put my money into? Do I put it in? I buy some new books every once in a while, and So yeah, I mean, that's my best advice. But patience and getting ready. Don't jump in, without any of that stuff behind you.
Yeah. Thank you so much. All really good advice. And since you mentioned a book, do you have any books you're reading that you're enjoying and you want to share?
Yeah, there's a couple of ones. Well, Intuitive Eating always. I really like it. It's not for everybody, but this one I just got. It's called the Radically Open DBT Workbook for Eating Disorders.
Nice.
I'm just starting with a client to work on this one. There's a couple of body image books. I use 8 Keys to Recovery.
Okay.
Yeah, there's a bunch.
Nice. Thank you so much, Ellyn. It's been wonderful getting to know you, your story, what you do, and the impact that you're leaving in this world with everything that you're doing for your clients and for future dietitians as well, and dietitians.
Thank you, Joyce. I appreciate you asking me on today.
So I hope we can connect some more as well. And again, just thank you so much. I don't see any questions, but if anyone has any questions, you can always post them on the group. And I can tag Dr. Ellyn there as well, if that's okay with you.
Oh, of course. Absolutely.
Okay. Well, thank you so much. Have a wonderful rest of your day. And thank you for everyone who's watching live or the replay.
Thank you, guys. Have a good day.